So now we move ahead with Dr. Shivam Gupta. Is he around? Dr. Shivam Gupta. Okay. So he is going to present the results of HFA 24-2 VFA, a challenge for the patients. नहीं सर, इन लोगों को नहीं होता है इनका. नहीं सर, अभी फिर से पूछ लूंगी जब एक बार एक.
Very good morning to all. Today, my topic of discussion will be Humphrey 24-2 visual field analysis, a challenge for the patients. So, glaucoma remains one of the leading causes of irreversible blindness in the world, and the gold standard for documenting progression of this relentless disease is perimetry. It not only serves as a tool for monitoring progression of the disease, but also plays an irreplaceable role in determining need for intervention. While visual field testing has undergone several modifications since its inception, the core principle remains the same, whether the patient identifies the stimulus or not. The aim of our study was to assess influence of patient-dependent factors on reliability of HFA, the objective being to identify and study influence of age, educational status, stage of glaucoma, number of times patient has reported done HFA previously, time of testing, and patient waiting time on reliability. So it was conducted as an observational cross-sectional study in our department, and 372 patients were recruited. The inclusion criteria being all patients above the age of 18 years coming for HFA, the exclusion being pre-existing neurological diseases, BCVA less than 6/60, refractive error more than 6, spherical more than 3 diopters, nystagmus and strabismus with loss of fixation or diplopia, any media OPC other than cataract, artifacts on testing, severe rheumatoid arthritis, or other diseases that would adversely affect the patient's response time, and pregnant women. So this was the methodology. Patient coming for HFA, routine examination was done, informed consent was taken, and procedure was well explained. After that, HFA was recorded, and the reliability parameters and mean deviation, pattern standard deviation were compared with age, gender, education status, waiting time, number of previous HFA, stage of disease, lens status, pupil size, and what time was the HFA taken, that is morning or post-noon. So we found subjects under age of 40 years were found to be most reliable. Males were found to be more reliable compared to females. In education status, we divided it into 3 parts, that is illiterate, school and graduates, and we found graduates were found to be the most reliable. Stage of disease, the subjects with advanced stage of disease were found to be most reliable. Waiting time, a waiting time of 2 to 3 hours were found significantly reduced reliability. Test post-noon significantly reduced reliability. There was no statistical significance among the reliability of patients who had performed HFA previously and those naive to the test. Eyes with clear lens were found to be most reliable, while pseudophakics were less reliable. Considering the age, most of the pseudophakic patients were old, that's why. Pupil size was not found to be significantly associated with reliability of HFA 24-2. So the final conclusion of our results was younger age, male sex, higher educational status, lesser waiting time, phakic patients were found to be significantly associated with increased reliability. Test in morning, that is pre-noon, was found to improve reliability. Prior experience with testing and best corrected visual acuity within limits were found to be no statistical significance in our study. In subjects who were partially reliable, that is, those who test reliability in one eye but not in the other eye, were again studied, and best corrected visual acuity, stage of disease, lens status, pupil size, and HFA time were compared. None of these were found to have significantly bearing on reliability of HFA. The strength of our study was, the sample size of our study was relatively large. Waiting time has not been studied as a factor of determining reliability in most studies. The weakening being, there were many confounding factors that cannot be discounted of. It could be ensured that all patients reach the same standard instruction. So what are the new things we can do? The role of technician experience can be studied. Mode of instruction, that is video, oral instruction, would be useful adjunct to the study. It would be significant to study each factor in details with appropriate control groups. Multiple factors determine reliability of results of HFA. Of these, we attempted to study patient-based factors. We conclude that age, sex, educational status, waiting time, lenticular status, and time of day when test was performed was found to be positively influenced reliability of HFA 24-2. Visual acuity and prior testing experience showed no significant association.
Thank you, Shivam. It was a nice presentation. Just a few questions. You said that the patient who were pseudophakic were least reliable. Any particular factor for that? Why did you think that it happened so?
Ma'am, actually, patients who have already undergone cataract surgery are usually older patients. So with old age, with the
That was the age factor you said. So again, it comes back to the age only because already you had made a criteria of age.
Yes, ma'am. Yes, ma'am.
Then second, you said, what about the phakic lens changes? Were all the grades of the cataract same in all your patients, or it was like different from NS 1, 2, 3, 4? What were the grades? Because it is going to be a big confounding factor.
Yes, ma'am. Definitely, ma'am. That's why we have. That's one of our limit and weakness of our study, that we should have just mentioned that whether the cataractous lens was there or not. But we could have done. Should have done even more grading of the cataract, depending on nucleus sclerosis or whether cortical cataract was there. We could have little further.
Because a PSC or PPC will definitely hamper, so you need to put that in your study as well. And what the last question would be that what about the stages of glaucoma? Like all the stages of glaucoma were similar in all your cases, or like it was from early, mild, moderate, severe? Any criteria on that?
Ma'am, actually, we had criteria early, mild, moderate, severe glaucoma. But yes, of course, ma'am, the readings were a little anonymous and.
Okay,
Dr.
thank
Shivam,
you.
I have a question.
Yes, ma'am.
So what algorithm was used, the CETA standard or CETA fast or faster?
Ma'am, CETA standard 24 dash. CETA standard.
Okay. So
Ma'am,
Uh,
yes, sir. Okay, sir. Okay, sir.
So thank you so much, sir. We are in short of time. So one last question.
Sir.
Voice come.
This session is not for audio
Yeah.
question, please.
Just one last question. The reliability indices are already there in all the printouts.
Yes, sir.
So what prompted you to do this study? Number one, how will it be of clinical relevance in your study? What is the clinical relevance? Can you change anything? You can only explain. That's why we take multiple printouts. We take a week, let's say, at least 3 times we take this
Yes,
thing.
sir. Yes, sir. Definitely.
Only then we rely on this. We never base our interpretation on one field.
Yes, sir.
And the reliability indices are all mentioned very nicely in all the printouts.
Yes, yes.
And how will it be clinical relevant, your study?
So I guess first of all, when we're looking for progression, these things matters a lot. Like we have to look what are the, like sometimes we are manually checking the fields for progression. Then these reliability indices has to be very well seen. Like sometimes we cannot miss this. And so
You're absolutely right. What I mean to say is the reliability indices are already there.
sir,
The reliability indices are already there in the printout.
Yes, sir.
For
Yes, sir.
every printout, there is one.
Yes, sir.
You can know whether you have to rely on this field or not.
Yes, sir. Yes, sir.
So, how will it be clinical relevant, your study?
So clinical relevance is that, sir, first of all, we are looking at the study. Our study was totally on what are the factors, patient-related factors, which are affecting reliability, not anything.
Will it affect the input and output of your the investigation?
So first of all,
In any case, you have to do the investigation. You have to do. There is no choice. You have to do the fields.
yes, sir. So it is on me whether how much weightage I'll give to this HFA field.
Weightage, it does not depend on your weightage. The indices are already there.
Yes, sir. Yes,
It's not your weightage what matters.
Yes,
It's the printout. It's the software that has been input in that machine for all the false negative, false positive, fixation loss and all that. It's already there.
Yes,
It's
sir, yes.
your interpretation doesn't matter. If he takes that printout anyway, he'll see that printout. He'll not say what your interpretation. He's not going to bother about your this thing.
yes, sir. Yes, sir.
see, all these factors influence, these are well-known factors which influence the field result. So I don't know what is new in the study. Even all the patient-related factors are well-known. Age, everything can influence. So because this fields, it's patient-dependent. The patient has to do the test, should have to concentrate, should need to have an understanding of the process of doing the fields. So these factors are well known, so that's why the reliability indices are there. So even the patient having systemic problems, even that could influence. Those are also patient-related factors.
If the fields were unreliable, first field, when did you repeat it for reliability? After how much time? If the first fields were not reliable,
Yes, sir.
Sir,
when did you repeat it for reliability?
sir, let's move forward. Sir, question is not for audiences. Here, question is for question will take.
So the question
chairperson
is,
will
if
take.
your
Next.
first fields were not reliable,
Yes, sir. So when
after how much time did you repeat it?
so minimum 3 fields has to be if I'm continuously getting a like we have to get minimum
What was
three.
the time interval between them?
So minimum 1 month, and then again 3 months we can do.